YouTube live.
Yeah. Yes.
YouTube live.
No,
PTS Ninga, you can start the proceedings. PTS.
So good evening to everyone. So on behalf of Tamil Nadu Orthopedic Association, I welcome you all to the 24th TNOA PG teaching program. Today's topic is all about locking plates. So we have an international speaker, Dr. J Dheenadayalan from COIMBATORE, Ganga Hospital. So our moderator for the day is Professor Dr. K. Meenakshi Sundaram. He is Associate Professor at Vinayaka Mission Medical College at SALEM. He is also a Medical Director at WIMS Hospital, SALEM. He is our TNOA team member. Presently, he is a video journal editor of Tamil Nadu Orthopedics. So previously he has held the post of Fellowship Secretary in TNOA. He is organizing Secretary of 2015 TNOA that's the annual conference of Tamil Nadu Orthopedic Association. He is a well-renowned trauma surgeon, replacement surgeon, and pediatric deformity correction surgeon at SALEM. So over to Dr. Meenakshi Sundaram, sir.
Thank you, Secretary, sir. Thank you, and welcome all the TNOA EC members and my well-wishers and friends, everybody. Today, I'm very proud that I am welcoming and on behalf of our DD sir, who is well-known, renowned surgeon all over the world and in India also. He has given so many lectures, and I don't think anybody needs any introduction because such a lovely person he is and very friendly in nature. He was now heading the trauma services at Ganga Hospital, Coimbatore, and he was the past president of Tamil Nadu Orthopedic Association, and he has met all the zone during his period and given so many CME programs. He was a very successful man and was liked by all of our colleagues, and he's a past editor of Tamil Nadu Orthopedic Journal, and he's a past AO Council member, and he is a founding member of APOA Trauma Section, and he is the first Indian to perform live webcast on nailing in open fractures from Switzerland. He has got many national and international presentations and publications in well-reputed journals. And more than that, he is a well-known trauma surgeon, and everybody in India as well as in Tamil Nadu, postgraduates know him as well as consultants know him. Very loving nature and very friendly nature. And today we are very happy and proud that he is with us to share his knowledge on locking plates, and I hope everybody enjoys it and gain more experience by his talk. And welcome you, sir, to our PGTG program, 24th PGTG program of TNOA.
Thank you, Meenakshi, for lovely presentation on me.
Thank you, sir. We are very proud, sir.
Thank you. So today I would like to talk. Is there echo?
Yes, sir. Now it will happen, sir.
Yeah.
Thank you, sir.
Okay. Thank you. So I would take this locking plates issue as like basically for postgraduates, this being the postgraduate teaching session. I want to present it as the way we all talk in our routine practice, and also the way I teach in my to my students. So it will be exactly the same pattern that I would like to present this. I thank the TNOA for all this endeavor. I think I heard that Thiru and the company is planning for 100 webinars, if I am correct. So
yes, sir.
One more thing. So
screen sharing varle, sir. Yes, we'll wait, sir. Now it started, sir. Started.
So our secretary PT Saravanan is with us. I thank our president TMS in his absence. Probably we are all and hope for everybody's health. And then with this, I start my presentation. So the locking plates, as you all know, that this is the trend as of now. Like anybody who wants to plate these fractures, the first thing they think about is now locking plate. In fact, As I speak about the principles, at the end I will also speak about a region. Like for example, I thought I will take the distal femur because most commonly used locking plate is in the distal femur nowadays. If you remember the history, or if you see when we all were practicing, lot of retrograde nails were being used for distal femur fixation. But presently, now for everything, now it has been like locking plates. So I thought I will start with principles in the beginning, and then I will also go on to take one specific area like a distal femur so that you understand every concept of a locking plate. And also, like Meenakshi, you take your time and then interrupt me whenever you want, and then ask any question. If there is anything like any chat box, anything questions are there, you can interrupt me and ask also, so that it can be some sort of interaction can be there, so that it doesn't become a monotonous presentation. So you all know that from 1886, when Huntsman was the first person to start implant surgery, and then to Lombard and Danis. Danis was the one, like Maurice Muller met Danis, and it all happened in 1958. The AO was formed. So it is Arbit's Gemeinschaft Osteosynthesis. That means like it is association of study of your osteosynthesis. So AOSF. So evolution, like if you take the AO itself, the initially 1961 semi-tubular plate came in, and then the dynamic compression plate, and then 81 they came out with LC-DCP. So this also evolved over a period of time. I'm not going to go in detail about the evolution because otherwise we'll be spending a lot of time on this. So this is how it evolved over a period of time. And then as it evolved, see the LC-DCP function, it's a DCP if you take, it is like if you have the hole that is on the DCP, which is also incorporated in LC-DCP, like what happens is in this compression side, there is a sliding mechanism like this. So first initially it glides like this, and it's like a ball, that is the chamfer, that is the head of the screw, will slowly glide, and then it will come towards the fracture side, so that it will also take the bone towards the fracture side. So that is the compression it gives. And also external compression can also be given using a Muller compression device. So these are important because whenever you operate, it is adequate compression has to be achieved with a plate fixation. So the axial compression that you give, many times, suppose if you are operating a forearm fracture, the regular DC plate that you use, that in LC-DCP, if you choose the DCP side, then it will give you an adequate compression. Whereas whenever you operate on a non-union, so where you want to give a good compression, excessive compression, I don't call it as excessive compression, but it must be reasonably correct enough so that all the fibrous tissue, everything will get nicely compressed. Compression, what it does is there is also metaplasia changes that happens for the chondrocytes. They all become osteoblast as well. So the compression is important. So basically, when you are doing a fresh fracture, many times when you use the compression side, that is a DCP hole, that itself majority of the time would be sufficient. Whereas in the situations where it is needed, you have to definitely use a Muller's compression device. So now as it evolved, like from when the AO was evolved, everybody started using like a rigid internal fixation, anatomic reduction. This was the concept. So a lot of people, what they did was like they exposed the entire fracture site, and then they saw the fracture zones, and then correctly made sure that it corresponds to the opposite end, and then fix it. So essentially what involved was a lot of biological stripping, like a lot of soft tissue was removed. And as the soft tissues were removed, the biology was getting disturbed. From that time, they realized that probably 58 it started. Around 70s, in that stage, they realized that it is not good enough to go on doing this anatomical reduction and rigid internal fixation. Better to go towards preserving the vascularity and the biology. So that is how the biological plate fixation came in. Earlier, like we were also using, like in a regular conventional plate also, we were using like this. Whenever this is a regular plate, this was a angled plate, that is a DCS plate that was used. And you can see that it was an open fracture. And then we also have used a small incision here, slided the plate, and then got it fixed. So this was, though it was tricky to use, and also it was very difficult to use this type of fixation with the very original plates way back like a DCS. But now you see, like with the locking plate that has been evolved now, it becomes simpler. So same technique can be made simpler with these fixations. That is the newer plates, pre-contoured distal femur plates. So that is how it was evolved. So initially you see a lot of mechanics, that was biology was completely disturbed. So entire bone was seen and then fixed. You can see there is an interfragmentary screw going in, and then it was neutralized here. And when it was done like this, definitely there is a stripping that takes place, and then it can result in avascularity and infection and non-union. But from then onwards, it has moved on, like instead of completely stripping it off, initially they just opened and then on the lateral surface. And then from then on, now it has gone on to a biological fixation where only the ends are opened, like as I showed in the previous slide. But you can see that the incision here is wider. You can see that the skin has been opened up. Whereas when the muscle plane is not open, so it can also be like a muscular window. See, like a biological doesn't mean that only you have to make a small skin incision. You can also make complete incision, but in the muscular plane, you just make a small hole. So just slide your plate through a hole. Don't disturb in between. Then that is also a biological fixation. So this encourages, when it is a biological fixation, it encourages a flexible fixation where callus formation will be good enough. When there is an anatomical reduction, so when there is an anatomical reduction and rigid fixation, what it does is, it is like an absolute stability. So it has to heal by primary intention. So it has to heal with bone-to-bone contact and then primary cortical healing. That is the primary intention. Whereas when it is done as a biological fixation, it is a relative stability. So when it is a relative stability, the strain pattern is between 2 to 10%. That means it will be a flexible type, whereas it forms by a bridging callus. That is a natural healing phenomenon that happens. So when there is a fracture, you all know that it goes through stages of healing. And those stages do happen when you do a biological fixation. So natural healing takes place when you are doing a biological plating. What is the advance that has happened from there to now? It is the combi hole. Combi hole in the sense, you can see that this was your original DC plate. And this is your additional locking hole. So that means earlier DC plate has also been incorporated to your newer locking plates. So it is a combi hole. So this plate can be used as a regular conventional plate. It is also an additional locking plate. So please remember this. It's a concept is you must use this as also a regular conventional plate. For example, when you are operating in a forearm, and then if your bone stock is very good, you don't have to look for a locking screws. You can just use your conventional screws. So you can use a regular DCP holes and then use it as a DC plate. Whenever, see, the locking mechanism or the locking plate was devised mainly for an osteoporosis. So if the bone strength is very good, still these plates can be used as a regular DC plate. That is where you have to differentiate how to use these plates. I will come to that later, but please remember this. This is the first concept you must remember. The plate that you are getting is not only a locking plate, but it is also a regular conventional DC plate.
Sir, like one doubt, sir.
Yeah.
Sir, in this combi hole, I've noticed most of the times when we put a normal screw without a locking screw in a locking plate, the reduction of the bone to the plate becomes more attached compared to a locking screw.
No, you have to choose a fracture. So you have to choose a fracture. For each of the fracture, you must differentiate. Is it a dynamic DCP itself is sufficient, or LCP concept we are going to use? Suppose the DCP plate that you are using, first is you have to definitely contour the plate, get it compressed, and then you can use the locking plate as a next phenomenon. First lag first, and then lock next. So
Yes,
you can
sir.
use the locking later on, so that
Later
you can
on. Correct,
increase the purchase of your screw holes to the bone.
yes, sir. Yes, sir.
So
The
that is
contour is good, sir.
yeah, that is the way you have to change your. So what is important is these plates, initially you have to look at the fracture pattern, and from the fracture pattern define what type of fixation you are going to use, and based on that you can choose this plate. That is the versatility of this plate. So what exactly you mean by a locked plate, locked implants? See, the implants are, you can see that the plate as well as the screw head is locked here. So that means it becomes a fixed. So it is an angle stable implant. It is like what was like an angled blade plate, what was like a DCS, what was like DHS, where it can be like, all those have got different mechanisms. But the concept is, let us take it as a fixed angle plate. For example, like dynamic condylar plate, or you can say that fixed angle, like a double angled blade plates that were available. They are all like a fixed angles. So those type, so it is also like a fixed angle implant because it is getting locked here. So this is the plate and this is the screw head. They get locked here, and that is why it becomes, the entire thing becomes a single unit. It is no longer, because before you introduce the screw, it will separate. Once you lock it, it becomes a single unit. So they are angle stable screws locking into the plate, and they work differently to a conventional plate. How do they work differently to conventional plate? You can see that number one is between the plate and the bone, you always get to see a gap. You can see there is a gap you can see. And that gap, this is a gap, and that gap is the one that keeps the plate away from the bone so that it doesn't disturb any of the vascularity. The vascularity is not at all disturbed. And next is, you can see that if you lock it, it won't come closer. If both the screws are locked, the plate won't be coming closer. So that is why whenever a scenario is there where you have to compress it, you have to use conventional screws first, compress it, and then you can spread across with the locking screws later. But if you lock first, then if you have not compressed it, the fracture ends will remain apart. So it will not allow it to heal. So this is the important concept you must remember first. So there is no compression across the fracture line if you lock it, even before a lag screw is put. And then the plate stands away from the bone so that vascularity is not disturbed at all. So basically you are looking at it is an internal external fixate. You are looking at it as an internal external fixate. In an external fixator, so if this is the skin, your external fixator, that is the locking happens outside the skin. It is happening outside the skin. The same concept, you are taking it underneath the skin now. So it is an internal external fixate. And also, like, if you all understand the Behrin's principles in external fixation, what do they say? In a Behrin's external fixation, they say that put a external fixator screw, that is Schanz pin, closer to the fracture site and away from the fracture site, expanding to the bone. This is the first principle in external fixation. Exactly, it is the same principle that you have to use in internal fixation, but with slight modification. The modifications are that I will let you know that how exactly the screws have to come in, how much of length you have to choose, and all those things will come later. But if you understand this, like what was
Sir, you are muted, sir. Yes, thank you, sir.
no, it says host as muted.
Yes, sir. Yes, sir. Got by mistake.
So it is, you have to understand that what was an external fixator has come back as internal fixator inside. So it is the same phenomenon. And then once you do it, so what happens here? There is, because there is no plate and then the bone coming close, so it is just staying away. It spares the periosteal blood supply. And also, like compared to a conventional plate, how is the locking plate different? It is different because there is in conventional plate, there will be a sequential screw pull out. For example, there will be first one screw will come out and then followed by the next and then the next. So what happens is here there is a toggling, that is between the screw and the plate, there is a rolling mechanism. There is a small type of movement happen place. And as it moves, suppose if there is an axial pressure and when there is a toggling that happens, it can also rotate. As it unwinds itself, then one by one it will come out. So it is a sequentially one screw after the other, it will come out. Whereas if it is a locking, what happens, because the entire construct is one, it has to cut through lot of bone before it comes out. See, like it has to cut through lot of bones. It has to toggle in such a way that it pulls out as completely as a different entire unit has to come out. That is why it is very strong. Actually, I had one video, I couldn't upload it into the picture. So it cannot come out separately. It has to come out together. So it requires a lot of force to come out. So that is why it is good to have a locking plates, locking screws, so that the bone holding capacity is better. And also, like if you take in the osteoporotic bone, so it is extremely useful because all the screws are holding together and then it will be very difficult to pull it out. It holds better. And also, like if you take the screws, the pitch of the screws is very small and the threads are very close to each other. And because they are very close to each other, in the cortex, it will have a good purchase. So that is why in osteoporosis, because there is multiple screws holding on into the cortex, it will have a better purchase. And also, suppose if you have a divergent screws going, then it will also give an additional purchase. So that is why the locking, especially in a metaphyseal locations, they make divergent screws in going into multiple planes. They all make it because it holds better. So these are the advantages in a locking plate. So that is why these locking plates are indicated in osteoporotic fractures. As I already said, it is a smaller pitch of the screws, and also like because there is no sequential pull out, it is entire construct has to get pulled out, the purchase is better. And also because it's a fixed angle device, metaphyseal fractures can be fixed better. For example, if you want to fix the metaphyseal diaphyseal fractures in a distal femur, proximal tibia, any of these metaphyseal diaphyseal junction fractures, and those extending to articular fractures, you can also use this. So it is excellent plate to use in these situations. And then it's a bridge plate. You can use this pre-contoured plate as a reduction device. They are manufactured in such a way it fits into the bone in the specified location. So you can use that and use it as a reduction tool also, and then use it as a bridge plating technique also. And in a periprosthetic situation, for example, you can also use unicortical screws. So unicortical screws will help it. So periprosthetic. These are the main indications for a locked plate. So I repeat, it is an osteoporotic fracture, a metaphyseal fracture as a bridge plate in a comminutions, and then a periprosthetic fracture. This is the main indication for a locked plate. But this locked plate, you also does not mean that it is going to be like panacea. So you have to know that this also has got a lot of learning curve, and you need to judiciously use it. And if you use it judiciously, then I think you will succeed in these fracture fixations. See, like all of them you can get into all these troubles, like screw can pull out, entire construct can pull out. See here, that is because it was just like unicortical screws have been used there. You also must know that, even if it is an osteoporotic, you must not end with unicortical, you must use bicortical, and only bicortical, and also increase the number of screws in osteoporosis. So the concept of mini max fixation will I be speaking about is valid, but if it is extremely osteoporosis, you must increase the purchase by additional screws. And any of the complication like plate breakage, screw breakage, or sometimes the infection, everything is a part and parcel of your orthopedic fixations. So that is why you need to plan very well, and this planning is going to be the key in your success. You have to make sure that there is a right size of an implant is available, and you also must become experienced enough to use it. The experience comes only on repeated understanding, listening to people who are doing about it. You have to go and see a lot of surgeons who are doing about these fixations. Only when you have a direct interaction and then see exactly what it is being done, and then you interact with them, why it was done, how it was done, how differently it could have been done. All this, if you put into every fracture fixation, and you will learn it in such a way that you will become the masters of fixation in later years. So the learning starts now. That is, as a postgraduates, your learning starts now, and get used to the principles very well. If you get used to the principles very well, remaining like performing a surgery is like you need to have, you have to start doing it. Only when you start doing it, you will understand better. But learning the principles comes first, which you will definitely do it in this space. Number one, like any of the long bones that you are operating, you have to make sure length, rotation, and axis. This you must not forget. Any of the long bones, length, rotation, and axis. Anywhere, upper limb, lower limb, metaphyseal, diaphyseal junction, shaft, articular metaphyseal junction, anything of that sort, wherever you are operating, you must make sure the length, rotation, and axis is correct. For that to be done correctly, you must always know what is the parallelity of this joint to the bone, how much of degrees of the articular margin to the shaft. This basically you must learn. And also in upper limb also you must know that how exactly the elbow joint line is preserved along with the humerus, along with the radius and ulna. How is your distal radius is alignment for the shaft. You have to know all the parameters like what is the radial length, radial inclination, volar tail, all those normal radiological anatomy you must be perfect. When you are perfect with the normal radiological anatomy, moment you look at any of the deformity, any of the deviations, you will be able to detect it. And for that, always remember length, rotation, and axis. Any deviation, varus, valgus, any malrotation, you have to immediately understand. And then the length discrepancy you will have to identify. This is the basis of any of the long bone fixations. So let us look at this X-ray. What has happened? So this patient had a combination over here that was fixed, and you can see that this is the fixation was very close to this fracture. And whenever the screws are very close by a nail, and if it is not holding to the full length, and it will go on to end up with a non-union. So anyway, nail all these mechanics and then the correct way of doing it. I think next week it is going to come up. So now you will discuss about the plates part of it. So in a non-union scenario, you have to get it right. So like what is important, you have to remove this. So this is a jammed broken bit, and then we are plating it here. And then look at this properly. You can see that there is a locking plate. And then you can see there are two screws. So these two screws are compression screws. That is the regular conventional screws. So it is important to know that on what stage of the plate fixation this has gone in. Supposing if it was locked first, and then these screws are gone in, what happens is the intervening plate becomes very stiff because you are compressing it to the bone after a fixed length. It becomes very stiff. So there is a possibility it will break. That is the first point. Okay, now let us assume that conventional screws only went first, later the locking screws. So then it means technically it was right. But in the post-operative care, what is important is these locking plates, you cannot make them walk immediately. You have to make them walk only when you see the callus. So the callus is any of the locking plate that you apply. The callus you see will be on the opposite cortex. So you always observe for the callus on the opposite cortex. If you don't see the callus on the opposite cortex, you must delay weight bear. You must not allow them to weight bear. Suppose if you allow them to weight bear, again the stress at the what we call the working length of the plate. Yes. The stress will be more and it will break. So these are the two things that you must remember. Number one, always make sure the conventional screws go first and then lock next. If you lock first and then lag next, that immediately it will break because you have stiffened the plate in the intervening working length. Suppose if your technique went right, unless you see the callus, if you make them walk, again it will break because the stress will be more for the working length of your plate. So these are the two things you must remember. Next, what you need to understand is how do you decide the length of the plate? As I said, in external fixator, you know that two screws will be very close to the fracture site and two will be expanding to the bone at the ends. Whereas when it comes to internal external fixator, you have to have this definition. So many times if you look, it will appear like, suppose if there is a simple fracture, let us take there is a simple fracture here. What should be the length of the plate? Length of the plate must be 8 to 10 times the length of this fracture line. Say for example, generally we use around 36 or 38 or 40 screw here. So let us put it as 3.5 centimeters. So 10 times means 35 centimeters. So it will be essentially the full length of the bone. So if it is a simple pattern, again your plate must be the longest plate that you use. Suppose if there is a comminution, then it must be 3 times the length of the comminuted fracture pattern. So you understand this. Even if you put it 3 times the comminution, then it means that it is you are putting it to the full length of your bone. So either way, it is the longest plate that you choose. Remember that whenever you plate, you are going to choose a longest plate. So you will never forget this. Sir, is this a small fracture? Should we go ahead and do a small plate? I will tell you again. Suppose if you are choosing a simple fracture pattern, if you are using a lag screw concept and a neutralization plate, then it doesn't matter. You can choose it is like your regular fixation with a DC plate. So you can go ahead to choose a smaller plate if you use a lag screw with a neutralization device. Suppose if you are choosing like a simple fracture, but you want to do a biological fixation, then it must be 8 to 10 times the simple pattern. So that means you are using the longest plate for a simple fracture if it is a biological fixation. Otherwise, if you are using it like a lag screw and neutralization device or a regular compression plate fixation types, then you have to choose like smaller plate means like you know that it must be a 4 screws on either side of the fracture pattern. That means 8 cortical purchases on either side of the fracture. That principle you have to use. That is a regular dynamic compression plate principle that we were using before must be used for this. This comes like 8 to 10 times the simple pattern fracture. 3 times the combination is for the biological fixation when you are choosing a biological fixation. A lot of people confuse this. A lot of people will say that let me use longer plate, but they will be using only the interfragmentary screw, but they will be using like this. So something like that you should not be interchanged. A longer plate still can be a neutralization device. It does not mean that you cannot use it, but you have to know how exactly what is the principle that you have used in each of these fractures. And also like the concept is like, how come there is an increase in the stress? Say for example, if the working length is more, on average, they have said that 3 to 4 screws in between the 2 screws at the fracture level, if you leave empty, that is 3 screws, empty holes at the fracture site, or at the most 4 screws, then there is a strain pattern is sufficient enough. The elasticity of the plate is good enough for you to throw the strain pattern sufficient for bone formation. That is why you have to choose a longer plate and with the empty holes here, so that the working length will be more and the strain will be less. And then once it is strain is less, it is better, bone formation will happen. Whereas when the working length is less, suppose if the 2 screws are very close to the fracture site like this, and then the strain will be more. Between these, there will be strain will be more, and then bone also doesn't heal, and then the plate also fails. So that is why you have to have empty holes at the fracture site. That is the concept. That is why the biological bridge plating that you use, you are leaving the empty holes at that site, wherever that is necessary. For example, in a combination, if you choose a simple fracture for biological fixation, so you must leave at least 3 to 4 holes empty at the fracture site. So this is the concept. As I said, from external fixator to internal external fixator, that is the locked plate. And then as you see it, this is how it became. So fewer screws and longer plates. So the longer plates improves the construct by increasing the lever arm of the plate. Longer plate requires fewer screws to achieve optimal fixation. The strain on longer plate is reduced, as is the strain on the screws. The fewer screws minimize damage to the bone. So that was the concept. But you see, in a metaphyseal area, you must fill all the screws at here, because the screw density ratio that we speak is 0.75. That means almost all the screws you have to fill it up near the metaphysis and articular region. Whereas when it comes to diaphysis, if there is say around 8 holes here, 4 screws you can put. If there are 6 screws are there, you can put 3 screws. But minimum you must choose is 3 screws, bicortical screws. So this is the Godson's mini-max fixation. So the mini-max fixation is like fewer screws and then the longer plate. So this concept over a period of time evolved, and these were the principles that were later came into. And then once these, nowadays, this is the standard. That is the length of the plate. How do you choose? 8 to 10 times the simple pattern, 3 times the comminuted pattern. And essentially, if you look, when you choose a biological fixation, the longer the plate, better it is. And then 3 to 4 screws must be left in situ, left empty at the fracture site. And then at the metaphyseal area, 0.75 is the screw hole density. So that means at least 75% of the screws must be filled at the metaphysis, and 0.5, 50% of the screw holes must be filled at the diaphyseal areas. So this already I have spoken. So 2 screws per main fragment with 3 cartridges are purchased for simple fractures, 2 screws and 4 cartridges for comminuted fracture. So that was the earlier thought process, but nowadays they have increased it to minimum of 3 screws in the cortex, that is in the diaphysis. So you can increase it depending upon the fracture osteoporosis. So there is not necessarily that only 2 or 3 must be used. If you think it is extremely osteoporotic, you can fill the more screws, but maintain the, at the fracture site, maintain 3 to 4 holes empty. So this is what I said. So span of 2 to 3 open screw holes should be left at fracture site. More the locking screws. Suppose if you choose more the locking screws, then it increases the stiffness of the implant. When it increases, when it is increased the stiffness of the implant, when the strain is more at the fracture site, it will break. And also I also said the screw length is important. Suppose if you have a screw, so see like there were also a screw with like a drill bit screws. So when it is like that, opposite side it may also irritate the soft tissue. So you have to be careful. So it must be just one thread can come out of the opposite cortex. Otherwise, they all can be retained inside. Only thing is that the screw thread must be onto the cortical purchase. Then only it increases the purchase on the cortex. So each screw, it is not only that you are thinking of the plate as a construct, but here in locking plate, it is also important that the number of screw threads that is holding on to the cortex is also important. So many times if the plate is not seated correctly, suppose if it is eccentrically seated, and if you are drilling only through the cortex, again it will not have a good purchase. So it has to be on the bicortical purchase. You have to make sure you go from the middle of the bone and then have purchase on both the cortex, both towards you and then further far cortex, near cortex and far cortex. Both cortex you must have a screw purchase. And this screw, because the pitch is so small and the thread is, many threads are there, and these are the threads that are going to increase the purchase on the cortex. And that is why in osteoporosis, it is extremely important that you get a bicortical purchase. Please remember this. In any osteoporosis, you must get a bicortical purchase. Whereas when it go in the same in osteoporosis, if it is in the near the articular margin, say for example proximal humerus, you are not going to go into bicortical in the articular margin. It's only the unicortical it will come. It will remain in the subchondral region. Whereas there are multiple screws going in different directions. When it is going in different direction, multi angles, then it is again going to increase the purchase. So that is the important message you must remember in this. So this is what I said in proximal humerus, when it is going in a different directions, it will be holding well. But if you do a mall locking, suppose if it is not going in the right position, see if you don't use a jig, and when you are not using a jig, it can go in a different direction. When it goes into different direction, then again it is, if there is a mall locking at the junction of the plate and the locking screw head, then again it will, sometimes it can come out also. And the mall locking also, sometimes we will find it difficult to remove it. So either way it becomes a very difficult scenario. So you have to be careful in doing this. So always use a jig, get into a right scenario. But there are now plates where if you, as the screw gets in, then that also can go in for, it can cut through the plate and then lock it. There are variations in there. So many types of plates are available. And these types of plates are different. So I think we will not go digress into the varieties of the plates, but let us concentrate on the principles. So always make sure that you use a jig whenever you are passing the implant. Because they are all pre-contoured and because they all fit into bone perfectly well, very rarely you need to contour it. Sometimes you may need it, but it will be very rare scenario. Because of that, you will have to, you can use these plates as a reduction tool. What is important is you must study the plate first. You have to take the plate and then thread your holes. You use the screw and then thread it. And then both you on the metaphyseal region or in the articular region near the tip, as well as both in the shaft zone as well as in the articular zone or just subchondral zone, you just thread it and study the plate. Lot of the plates you will see that the screws are designed in such a way that the most proximal screw near the articular margin will run parallel to your joint line. And then in the diaphysis, you will see that all the screws will run perpendicular to the long axis of your shaft. So you have to first, but not all of them will copy the same. See, like some of the companies will make it different. So that is why you have to take it out, first see, and then study the plate. Put it across your table and see whether how many degrees it will make an angle. So in the shaft, if I keep it, if it perpendicular to the long axis, what is the screw axis that is going towards your plateau, tibial plateau line? Or if it is a distal femur, how much of angle it will make towards the articular margin? So first study that. If you study that, then 100% of the times you know that how exactly you can reduce these plates. You can use this plate. You can play with these plates. You can play with the plate, and then you can make sure that you can get a right axis. You will get a correct positioning. Everything will come. So most important is that many of the people don't study this. Without knowing this, when you go and put it, then it will be, screws will be in some direction, and then your alignment will be changed. Everything will be like some of the times you will get into a disastrous small alignment. So that is why all of you as a postgraduate in the beginning, take the plate, study it, go and then discuss with your nurses. Take the plate and then completely see how exactly it is aligned. Put the screws, don't over tighten it, just lock it with the finger tightness and then see how the way these screws are all going. Then you will get a fair idea of how to put it on the patient. If you don't do this, then you will not get a good idea of fixing the bones. So now let us look at it. Now that having understood the plate first, now you need to know that because you have a one type of an implant with you to play around, but a patient comes to you with a fixed pattern of a fracture, isn't it? He will come with, say, if it is a simple fracture, or it can be an oblique fracture, it can be a comminuted fracture, or it could be like a fracture in the metaphysis involving the articular margin, or there can be a diaphysis fracture and then a metaphysis and an articular fracture as a segmental fracture. So now first study the fracture personality. If you study the fracture personality, then you think what type of a stability that you need to give. Many times for a shaft fracture, you may have to give a relative stability. Whereas when it comes to an articular margin, you may have to give a absolute stability. So you have to think, okay, let me first fix the articular margin, get it an absolute stability. You can put the interfragmentary fixation first and then get the diaphyseal situation ready. Suppose if there is an articular fracture involving the metaphysis, articular fracture, you can fix it like an absolute stability. Use screws and then fix it, and then you can use the metaphysis as a relative stability. You can use a biological bridge plate. Sometimes there can be a simple fracture. Say, let us look at, take an example of a forearm. In a forearm, there may be an oblique fracture, or there may be just like a transverse fracture, which requires a good compression. If you want to use this as a good compression, take the locking plate. You can also contour the locking plate. Only thing is, when you are contouring it, there must be there are many methods to contour it. You must make sure that the locking sleeve goes into the locking holes and then tighten it so that it doesn't deform. And then on the conventional, that is on the side where there is a DCP side, then you can slowly contour it. So it is a technique that you need to follow. So when you do that, first use conventional screws and then get it compressed. After that, remaining screws, you can do a locking screws. Suppose in a very young patient where the bone stock is very good, you don't have to use a locking screw at all. You can use it as a DC plate. So that is what is important. Suppose if there is a butterfly fragment, you are getting a patient with a butterfly fragment. So you are thinking that you can use it as a, first you can use as a lag screw first and then get the fracture reduced. And once you have put a lag screw, then you can also neutralize it. The forces across can be neutralized with an additional plate there. For that, you can use the locking plate and then use it as a, so it is a principle that is used. You can use a lag screw with a neutralization device. You can use it like a regular compression plate, and then you can use it like that. Or you can see, like if you have attended a basic course, you will be taught like how exactly to put a compression screw, that is interfragmentary screw through the plate, and interfragmentary screw without the plug. Initially you can put interfragmentary and then neutralization also can be done. We will also be taught that you can use this plate through the hole itself. You can also put a interfragmentary screw. So like that, a lot of principles you will be taught. All this can be used. This is a plate which is so versatile that all the principles can be used. So first study the fracture, apply what you think has to be applied to the fracture, and then use the plate. Do not think, okay, let me have LCP, put the LCB, and then many times you are not interested in bending the plate. You just want to put it and come out, it may not work well. Suppose if you just go and put a locking plate, you may not achieve a compression. As in the beginning, in the first slide, I said that moment you put two locking screws, it is no longer getting compressed. It won't compress unless and until you first use a compression screw and then go on to use a locking screw. And of course, when you get a comminuted fractures, the best way is to preserve the biology and use a bridging principle. So if you use a bridging principle, that is the biological plate fixation, that is the concept that you will use. And all of them, like for example, as I already said, if you use a distal femur plate, if you are using a metaphysis comminution and also an articular fracture that you are fixing, articular can be, an absolute stability can be given by an interfragmentary fixation first, and then a biological plating can be done using this plate. So it is a combination of the principles you can use. So when you are taking it as an absolute and relative stability, you can use any method of fixation that you want to use, you can use this. So that is why it is, all these LCPs are such a versatile kit, and you can have it as a single armamentarium, single implant in your setup. Already I told you this application is based on the fracture pattern. So you are using it as a neutralization device to protect the lag screw. And in a metaphyseal location, like when you are, say, for example, a distal radius you are operating or a proximal tibia that you are operating, you can all use, it's like a support plate. You can use a buttress plate. So it's a supporting type of a plate. Of course, I told about the bridge plate. Tension band. See, like suppose you are using a plate, say, on the lateral side of your femur. Lateral side of femur is a tension side. So what is important when you are using on the lateral side of your plate on the femur, the opposite cortex must be intact, because the compression cortex, if it is not intact, and if you are putting a plate on the tension side, it will fail. So always this principle you must remember. If you remember this, you won't commit a mistake. So that is why in a femur, if you look anywhere in the femur, medial void, if you see like subtrochanter medial void, a midshaft medial void, or a distal femur medial void, if there is a void on the medial side and you put a plate on the lateral side, all the locations it will fail. The concept is, this is the concept you must remember. Whenever you operate and put a plate on the tension side, the opposite side, that is the compression cortex, must be intact. Otherwise, you must go for a nail. If you remember this, If you don't opt for it, then you must choose something else. Suppose if you are saying that nail cannot be put in this situation, I'm going to use plate, then you may have to use two plates, either medial and lateral. Both sides you may have to use. But anyway, that depends on the location of the fracture pattern. But remember this concept. Suppose in the lateral side of the femur, when you are putting a plate, opposite side must be intact. In a distal femur locations, many times when there is a combination, it may not happen that opposite cortex is intact for you. But that is where you have to use wisely how exactly you use a biological fixation and how exactly you use a plate, how exactly you use a nail, and how exactly you use a bicondylar plate. So all these thought process must come in. If you remember this, automatically all the concepts will come into your mind. If you don't remember this, you will put a plate and many times it will bend or break. So that is why it is important. Suppose if you put it on the compression side, it is okay. So many times it will heal well. So, but always when you put a plate, if you have a chance, to put a compression device, you always try to use it. And whenever you are using a compression device, this is also important. I will also go through that in a later slide, how exactly you use that compression mode also. So here I said that all these plates can be used in different patterns based on the fracture pattern. I also told about how exactly LCP works. But you see the modes and techniques of use is based on whether you want to use LCP as a conventional plate, as in the form of an absolute stability, whether you want to use it as a bridge plate in the form of a relative stability, a combination fixation, or a buttress plate. And this is what you have to look at in every fracture. What type of principle I am going to use? What type of the mode of fixation that I am going to use? If you first come to that understanding, you will never go wrong in the method of fixation. So this is the basis of your locking, your plate fixation. So if you understand this principle, you will never ever go wrong in your fixation pattern in any patient. So it is important, like I'm telling about compression. But what is important is, say we are operating on a humerus. Humerus, many times you will do with a plate fixation. So suppose if you put 2 screws in the beginning and then take out the plate, bend the plate. You bend the plate a bit, pre-bend it, and then go through the same hole. Then you will see that the opposite cortex will compress. See, like first you put the first with a flat plate, you put 2 screws in the eccentric slot, and then take out the screws, take out the plate, and then bend it. Not too much of bend, a little bit of bend you have to give. And once you give, you must go through the same screw holes, and then you will see that the opposite cortex will come closer. So that is the opposite cortex will come closer. You are giving a good opposite cortex compression, and that is a primary requisite for any of the plate fixation so that it will not fail, number one. But it is not sufficient. But if you also combine it with an axial compression, say like now that you have bent it, automatically the opposite cortex will come closer. And because the eccentric slots, drill guide if you use and then compress the plate, use the screw holes, then it will also glide the bone towards your fracture site and then give a compression. But if you use external compression also you can use. If you use external compression, both far as well as near cortex will come very close. It will be like the compression will be uniform. The entire circumference will be nicely compressed, and then that will allow it for a primary healing. That will get into a healing with primary intention. Absolute stability you would have given. With compression plating, you would have got into a healing of a primary intention. So that is important. That is a cortical healing you would have got it. So remember this concept. If you understand this many times, if you follow it rigidly, I think you can achieve a lot of success. Okay, we have already discussed about a lot of principles involved in a plate fixation. So this also I have told you about using first use the standard screws. This is the same example that has been told. But what is important is before even you put any of this, like when you want to nail, first thing you are saying is, have you reduced it? Similarly, when you are doing a plate, have you reduced it? It is important. You have to achieve a good reduction. Of course, you can also achieve reduction after a plate. You can also you can play around with the plate and then you can try to see whether there is any cortex that is migrating. You can try to put a compression screw and pull the fragment towards you. All those things you can see and then at that time. But you must have a game plan for any of the fixations. So reduction. So one of the area you must remember is a spiral fracture in elderly. A spiral fracture in elderly is a biplane. It is not in single plane. So it is a biplane fracture. You will see that many of the fractures that you are all having a problem, it will be in a spiral. Actually, today also I did one spiral fracture. So what first thing I do is I have to get it reduced. Many times you can see that you put traction and then you give an adequate support on the medial and the posterior side, you will see that all of them will get reduced. But as you start putting a plate or as you do it, it will slowly, one of the spike will go out or something. Best is to get it reduced. One of the best way to reduce it is use a cerclage wire. Earlier, when we were all, when I was a postgraduate, the moment they see a cerclage wire, they used to say it is a crime. But it is not like that. Now with the minimal invasive techniques coming, and then now that cerclage wire also has been said to be a minimal invasive. So you can go ahead to use a minimal invasive. So best is in the ends of your spiral fracture, have a cerclage done. And once you know that the way you get it reduced by internal or external rotation of the fragment, because if you keep giving traction and then trying to manipulate with your hand or the implant, it will break. So basically, automatically your fracture will get aligned both in medial lateral as well as anterior direction. And then as that is done, then it is easier for you to plate it off. You can use a minimal invasive or so. Make sure that you do with small incisions. Even if you don't use a smaller incision, you can go through a muscular window. Muscular window also. Ever think that bigger the incision is non-biological. You can make a bigger incision, but you have to go through a muscular window. That is also biological fixation. So see the get a to go to good union. This is what I was also telling, like you have to correctly centralized. If you don't get it centralized, you won't be critical. So sometimes you will end up having it into only on the one, and then it will cut through. It will not have a pass. When you text alone, there can also be a thermal necrosis. When there is a thermal necrosis, again it can end up with some infection and also problem. And then you go to both sides, both cortex. One of the understand is moment you pass the first cortex, you should have a resistance, and then the next you will have a loss of resistance, and then one more resistance will start coming in the center of your implant. Otherwise, it won't hold. So you have to be very careful with that. And then to centralize your plate, and then your K wires. So you can see that you can put your plate here, and then if you want to centralize it, you can put a K wire next to the plate, and then again you can put K wire, go ahead on the K wire, and then use the K wire as a joystick, and then bring the plate down, and then you can also put your plate correctly centralized. So it is the KOI. This is the Kretek's technique. The Kretek is the first person who wrote about it. And then this, you can use screws that is K-wires above and below the plate, and then make sure that it is centralized. If you go through the hole, what happens is sometimes when you are giving traction, suppose if you are given excessive traction and then you have gone through the hole, that means that distraction would have maintained, and then if you plate it, because in distraction it will go in for a non-union. So that is why don't go through the screw holes, go above and below the plate so that it is centralized. And then when you are giving traction, or when you want to, when you are giving an axial compression, it will correctly get position. That is the point of going above or below the plate. But you also must remember these new techniques also will have a newer problems. So they will have, like, you might have used it for poor indications, or fixation principles you won't have considered, or region specific considerations might not have been taken care of. All those is important. So because I wrote this slide, I want to talk about, because most commonly used locking plates are either in proximal humerus or in distal femur. Of course, yeah, proximal TB also nowadays being used a lot, and then distal TB also is used, but I thought the most common would be the distal femur. I will take the distal femur to discuss the region specific considerations. So at this stage, any questions are there, I will take, because I am sure that already I spoke for half an hour. I'm not sure how much time I spoke. So,
Sir, can I just ask one doubt, sir?
yeah.
Sir, about the length of the plates, you said about 8 times and 3 times. Can we take it like this? Can we take it for a you said about simple and comminuted fracture, sir. Can we take it for transverse fracture and oblique fracture, sir? For transverse fracture, it is 8 times, and for oblique fracture, it is 3 times.
Yeah, I said simple because to differentiate a comminution. Any of these transverse or oblique, you have to choose that way only. So that's what I meant as a simple fracture. So
okay, sir. Yeah. For them to easy to understand this transverse and
yeah.
Sir, there are some questions in the chat box, sir.
Yes, sir.
First question is, can we use lag screw and the plate in different planes, or it should be used in the same plane always?
Lag screw
and plate in different planes, or it should be used in the same plane?
See, the lag screw concept is like if you are using it for a long spiral fracture. Anyway, it will come in a different directions, because you have to go through the apex on one side and the other apex on the other side. It will go in a different angle. Suppose if it is an oblique fracture, in oblique fracture, you will put it in one plane only. You can't go in different direction. You have to go through only in one plane, that is perpendicular to the fracture site. Am I making it correct for you?
Yes, yes, sir.
Yeah. So that is how you differentiate. In a spiral, it will be in 2 different directions, because it is a biplane fracture. Whereas oblique fracture is in a single plane, and then you will go through perpendicular to fracture in one angle. So you can't put it in different angles. So this is a fracture specific. Any other questions?
Sir, one more doubt, sir. Sir, in case of, you told unless the callus is formed, prolong the non-weight bearing for a couple of weeks, you mentioned, isn't it, sir?
Yeah.
Sir, what happens is most of these patients, when we tell them not to weight bear, they somehow land in their leg and go to the toilet and come back. So to prevent it, most of the times we are forced to use a POP slab. But nowadays, wearing a POP, it's very cumbersome for the patient. What is the method that we can tell the patients not to weight bear, or try to prevent any other method is there apart from this POP?
No, the patient compliance is extremely important. The best way to do the patient compliance is to do a fear. You have to instill some fear, like corona fear. No, like many times now everybody is worried about corona means. So like that, if you warn them on day one that If there is a plate breakage, it is not because of the plate, but because you have
Weight
taken the weight, you have done the weight bearing. If you
Okay, sir.
tell it on the day one,
Yes, sir.
tomorrow when the same patient comes to you also, he will not say that it is because of the plate.
Sir, one more doubt, sir. Most of the patients, when they come, they will tell us, sir, put a plate which is biodegradable. It should melt by itself within 3 months. Ganga Hospital is doing that. So what is the solution for this, sir?
No, we don't have a biodegradable implants. We don't have
Yeah,
that.
yeah, we know it, sir. But the patients are having a strong impression that they don't want a stainless steel. They want a one which melts within 6 months or 1 year.
No.
I don't know. The wrong concept is going around. I don't know. I've faced a lot of people who ask me. So I think most of us would have faced these questions.
No, it is not only you. Here also they ask. For us also they ask. So everybody says there is a biodegradable implant. Can you put it? We say that it is not available in India.
Okay, sir. Right, sir. Okay.
So, in other words, to ask Meenakshi's question, sir, is titanium or stainless steel? So, how different it is? Because people do prefer titanium when the cost is there. Is it really going to matter if you put a stainless steel plate or a titanium plate?
No, it doesn't matter. It doesn't matter because
It's
if
not
you
going to
see,
matter.
it doesn't matter because in America it is more or less it is a stainless steel plates that are in use. In
Yes,
other
sir.
parts of the world only it is the titanium implants. So it is not this thing. The problem is in US. I asked many surgeons why in US they are still using a stainless steel plate. It is purely because of the implant removal. So a lot of titanium implants, they are having trouble in doing an implant removal. Whereas stainless steel, it is very less.
And
But
only about
when
the
you
MRI compatibility.
Yeah, MRI compatibility, both will give an artifact. So I don't think there is, but stainless steel gives you more artifacts.
Okay.
Both of them will give you artifact.
Yes, sir.
So there are few more questions. One question is, sir, please tell the order of screw fixation.
The order of screw fixation is like, as I said, it is depends on the principle that you have chosen. So suppose if you have chosen to use the regular DC plate type of fracture fixation, where you want to use the compression screws on either side, first one neutral guide, and then put a screw, and then next you use an eccentric drill guide, and then use compression. And once you achieve it, then you can choose a locking screws. That is the way you have to use. So anywhere, any locking plate that you use, if you are using any reduction methods using screws, it will be a regular conventional screws first, and finally end up using a locking screws.
Okay, sir. Thank you, sir. There is another question. In bridge plating for a comminuted fracture, is it mandatory to leave at least 2 screw holes from the fracture ends on both sides of the fracture?
In comminuted fracture?
In comminuted fracture also, is it mandatory to leave two holes from on either side of the fracture ends?
No, that is you mean at the fracture site?
Yes.
At the fracture site, in comminution, you have to leave 3 to 4 holes empty. In fracture like simple fracture, that's what I mean is a transverse or a short oblique fracture. If you have chosen a biological fixation, again there also you will use 3 to 4 holes empty.
Okay, sir.
That is, if you choose a biological fixation. See, this concept is for biological fixation. Do not mistake otherwise. It is this concept is to be understood very well. When this concept of leaving the 3 or 4 holes empty is only for biological fixation, not for any other type of fixation. So that is why I'm telling repeatedly that first study the fracture, understand what type of principle you are going to give, and based on that you apply these plates.
Thank you, sir. There is one more question. Even after following the principles in humerus for plate fixation, why humerus is always going for non-union sometimes? What is the reason?
Oh, any bone can undergo non-union. There is no doubt about it. See, like not only humerus, any of the fractures can undergo non-union. So there is nowhere in the world that any surgeon would have achieved 100% success rate. But you must understand that any fracture, you must think, if they go to indigenous method of treatment, if they go to any fracture, closed fracture, if they go to indigenous method of treatment, nearly 60 to 70% will heal without problems. We are taking that from 70 to 95% by our fixation methods. Orthopedic surgeons are taking it to nearly 95% by using correct principles. Nowhere ever they will take it to 100% in anybody's hands. Even if you take any of the statistics, any literature, they would have. The only literature that shows 100% success is in a non-union where they have used a nail as well as a plate, augmentation plate device. There are Korean articles which has given 100% success rate. That is the only articles which has given 100% success rate. So that is why do not be worried about which of them are going in for a non-union. But as you operate, if you are fixing it, if Thiru is operating, I should not say Thiru has done something wrong. If I operate, Thiru should not say that I did something wrong. So this is uniformity in fixation must be established. That is the only concept with which I am talking about. So non-union can occur, say for example, it is not only because of your fixation. By injury itself, if there is a comminution, when there is a high velocity injury, if there is a soft tissue problem, if there is an open injury, if there is an indolent infection, some sort of infection underneath which is not clinically manifesting, somebody is a smoker, somebody is a diabetic. See, like a non-union is something not only like your own problems, it is patient's problem and also additional metabolic problem. Everything is combined together. So do not worry about it. But as an interventionist, as we are intervening in between in the patient's life, we must make sure that we have done our job correct. So please understand this one. All fractures can undergo non-union. So do not go with an idea that, okay, I did the great job, but it is, see, like best of the fixation can end up with non-union. Worst of the fixations can end up with a good union. So keep it apart. But when the fracture comes to you, have you done a right job? That is what you must go with an idea. If you go with that idea, yes, you have won the game.
Thank you, sir. I think these are all the questions in chat box. We can proceed, sir.
Thiru, inna evlo neram Thiru?
You can take.
Sir, you can
take your own time, sir.
No problem, sir.
No issues at all, sir.
Sorry, then I will play one video and then proceed.
Okay, sir.
So this I'm playing because see, like this post TKR, and then once you are doing this, most important is what you have to get an alignment. So see, like this a long segment combination was there, and then you are doing a minimal invasive surgery. When you do a minimal invasive surgery, few things that you have to know. Number one, see, like I chose the fracture where it is a periprosthetic fracture. In a periprosthetic fracture, for the longevity of the prosthesis, you must get back the alignment right. So that is what is important. So keeping that in mind, you have to operate. When you are doing it, see, like these are the points that is very important. So now I said all these points I already told, like how to position it in the plate and all those things. So here you see, like what I'm trying to do. This is the only point I want to bring it here. See, like the medial cortex must come in continuity. Always, whenever you want to plate, if you put a screw here, what will happen is it will pull the fragment, everything towards your plate, and then there will be a discontinuity on the medial side. If there is a discontinuity on the medial side, it is always like complete medial void. So your plate will fail. That is why you must use this stopper. I would already put a screw on the distal side here. Now I am bringing the shaft into an alignment. So what you can see that there is something in between going, but see, like this is I have made like 6 mm rods, 8 mm rods, like that we have. What I do is I introduce it between the bone and the plate, so that I always try to keep the shaft medialized, so that the medial cortex will come in continuity. Only when the medial cortex is in continuity, then whatever the force happens on the medial side will allow it to heal well. And also, like, this is the other part you must remember. Oops. So you see, this is the cautery wire. You must make sure that the axis of the hip, that is the center of the hip, center of the knee, and center of the ankle must be in line. In every case, you practice it. Use a long arm where you have to get a C arm. And then once you know that you are in the axis, you will know that you have done a right job. So these are the few points that I wanted to bring it in this video and show it to you. So once you know that you get it correctly, and then make sure that everything, like first check in the ankle, and then make sure check in the hip, and then come to the knee joint. And when it goes in the center, then you know that you have got it into right alignment. This every case I practice. So if you do that, there will never be an issue in getting your alignment correctly. The remaining, of course, it is the completion of your procedure. And once you complete it, then everything will be in order. So always achieve good reduction. That is the first point. And plate positioning is important. See, like this is what somebody was asking, like a screw. See here, this is a screw. What has happened? There was one interfragmentary screw away from the plate, and there is also screw going through at the fracture side. So this is a fracture, and then there is a screw going. So it means screw is in different planes. So actually, when you are using the lag screw, this just need to go in as this one just needed to go as a neutralization device. If you don't follow that, then it will end up with the problems. So it's, you see, like this doesn't serve any purpose. It is not only like that. Here you could have lessened the working length, because you see there is a lot of holes in between. You see, like here there is 1, 2 or 2 or 3, I don't know, but 2 holes definitely is empty. And then here at least 4 holes will be empty. So it becomes like a very long working length. Because you have put one screw here, what essentially it does is it increases the stress over here. And this is a fracture pattern. And then when it increases the stress, automatically it is going to end up with bending. So that is why you must not mix match with your principles. If you use a lag screw, use it correctly. You could have used one screw, one lag screw here and one lag screw here. See, like when you are using in a long spiral, you know that the 2 lag screw will come to the end of your spiral, and one can go in a different direction, the center. So like that, if you distribute your lag screws and then neutralize it, it will be a best way to do it. So this is the way, then it ends up with failure. And also, like as I already told you, all the plates that you have, first understand the plate. See, like this in this plate, the center hole here will always run parallel to the joint line. So if you run that parallel to the joint line, then you will get articular margin block and the metaphyseal block correctly into the plate. Then if you play around with a conventional screw to bring it closer, you can bring it closer. Or you can put a block here and then use a conventional screw and make sure the medial border is correct, and then lock this. You can put a locking screws. Once you do that, then you see, like I have got 3 screws here. There is no need to fill in the screws here. If you have adequate cortical purchases, that is sufficient. But what is important is, here at the fracture site, you must have left 4 holes or 3 holes empty. Minimum 3 holes you must leave. Maximum 4 holes, 3 to 4, 3 or 4. That is what is important. More the holes you leave empty, then it becomes increased elasticity. So it will fail. Lesser the holes, it becomes increasingly rigid, it becomes stiff, strain will be more. So again, it is going to fail. So parents studies have proved that 3 holes is adequate enough. 4th one, if the combination doesn't permit you to put a screw closer, 4 holes is okay. So this is what is important. So run the screw parallel to the joint line, and remaining, of course, you will understand. So one of the problem is small alignment. So if you understand the plate well, you will prevent this. And also, like, this is what I said. Suppose if you put a screws, so you will pull the entire shaft towards the plate. If you do that, again it becomes a medial void. This again you must prevent. So that is why I said you have to use the block. So if you use it, then you can push it, and when you manage a non-union, it is totally different. Here I have used something different, but it is beyond the scope to discuss in this lecture. And here again you see, like, you already know that in these fractures you have to have a bump underneath here so that you nullify the gastrocnemius pull, and then it will be in a right position. And again, this is whenever you get a scenario where your rotation is not all right. So this is what rotational axis must be corrected. If rotation is not correct, if there is some of the spike that is coming off like this, you can see here. So if the spike is coming off like this, that means gross rotation has happened. If there is a rotational malalignment like this, it will never match here. The diameter discrepancy will happen. If there is a diameter discrepancy, again, it is going to be like your medial void. It will again fail. But if you draw the cautery wire test here, it will be abnormally be in valgus. It will not be in the right alignment. So these are the few tricks that you must remember. So length, rotation, and axis, all the 3 must be perfectly be aligned. So they will end up with this. Already I spoke to you. And then this is one of the important thing you must remember. See, like many times, how do you get your diameter correct? Unless and until you collapse the metaphysis. Lot of people will not do this. If you collapse the metaphysis only, the diameter will match, the proximal and then the distal diameter will match. If these 2 match only, then you will be able to get your medial alignment correct. So that is why one of the best way to do is first concentrate on the articular block and the metaphyseal block. Metaphyseal block must be collapsed. Articular block must be correctly be fixed, internally fixed with separate screws. If you do that, then you come to your fixation of the alignment part of it towards the metaphysis. See, like, first you collapse the metaphysis and then get the fixation done for that, and then get your diameter. See, now it will match. If you don't do that, it won't match. After that, it is just to get your screws and then get it completed. So the metaphyseal splaying, that's what. If you don't collapse the metaphysis and if it remains open like that and then put the shaft, it is again going to be like your medial void, because the medial continuity won't be there. See, like here it is, metaphysis has not been collapsed. Here metaphysis has not been collapsed. So see the diameter here and see the diameter. If anything that is closer here and if it is not coming towards your medial cortex in alignment, then again it is not going to match. Again it will fail. So you have to watch all these. So this is how it fails, and then you will have to correct it later. Always observe for the callus. If you observe for the callus and then make them weight bear. So this point I have already told. Working length again I have already told, and then if you get this working length and all correctly, then they will all heal well. And remember this also, like this also I got it because majority of the distal femur, if only it is metaphysis, articular margin, if you draw, you know that the fracture, suppose if you want to put it as a metaphyseal block, what is the metaphyseal block? You have to know the diameter here, and exactly the same diameter, a square has to be drawn. So this is what is your metaphyseal block. And that square, if beyond that, if there is a fracture, they are all amenable for nailing, retrograde nail. Please remember this. Lot of people, moment it is written as a distal femur, the first option they think is only a plate, locking plate. Lot of them, I have seen many patients. But these are all amenable for a nail. If you put a nail, nailing is a good option in these type of fractures. Nail will give you better result than your locking plate. See, this is the fixation. You know that now you know all the principles because both the screws are very close to the fracture site. You know it is going to be, stress is going to be very high, and then it is going to end up with failure. So once, what next you can only do is remove it and put a nail with bone graft, augment, then it is going to heal well. So the common complication that you all get is a malalignment. Because you are going to use it for an intra-articular fractures, for example, proximal humerus, you are going to end up in the subchondral because the plate is locked to the screws. If there is any collapse or any of them, or if there is any of the varus collapse that happens, the screws will cut out. So there will be intra-articular cutout will happen. And then the locking screw breakage. Locking screw breakage happens because when you are making them weight bear, the force concentration happens at the locking plate junction. Locking, that is the screw and then the plate junction. So at the neck portion, that is the threads will be there. Next to that is the neck and then the threads will start. That neck junction will be the area where you will see that lot of screws will break. That is also because of your axial loading. And of course, I told you about the plate breakage, mall locking also I told, and implant removal problems also will happen in this. So these are the common complications that happen in locking plate. We are coming to end. So that's why I said that for completion's sake, I will put these complications that you need to remember. And if you remember these and the principles that I told, that all these principles must be used only on the fracture pattern that you get, you will get a good result. And for removal of the implant, so don't just, when the patient comes to you and then you just don't post them without having these instruments. You must have all the instruments like a reverse threaded locking, reverse threaded, and then you must get a carbon drill bits, and then it has to go through then the mill to remove the locking bolts, everything. And then there are square nuts, that is because all of them are hexagonal. There are square shaped, what is it called? Screwdriver tip. So because in the square tipped ones, if you jam it in, it will get locked into the screw and then you can remove it. So there are many varieties are available in the market. You can go through it. All of them you must get it. And then if you get it, then you can remove all the broken screws and the plates. Many times it will be so difficult that you will have to cut off the implant also, whatever is projecting out or whatever that is there, or you will have to cut the plate and remove it. So many methods are there, but you have to be prepared. So this all in nutshell, or whatever that is, whatever the maximum points that I can give it to you, I have given. So all the postgraduates, if you have concentrated enough, the amount of information that I have given you will be, it will worth $1 million for you. And then if you practice tomorrow, you will be a great surgeons. Thank you all.
Thank you, sir. Thank you so much, sir. Excellent topic, sir. Excellent. I think the postgraduates have been benefited by today's your lecture, sir. And we also understood some fewer points. We also gained knowledge, sir. Thank you so much, sir.
Thank you.
Doubts,
Thank you,
sir?
Meenakshi.
Doubts? Sir, Tanapan, sir.
There are two more questions in the chat box, sir.
Okay.
One question is, sir, can you please explain the concept of metal block?
Sorry?
Can you please explain the concept of metal block?
Metal block. So it is not. So if you had seen that video, you would not get this mental block. See, like what I mean is, see, like now, I put a plate here. Suppose if I put a screw and then conventional screw, if I put it and then thread it, what happens? It will pull the fragment. It will pull this fragment towards the plate and then end up with a medial void. To prevent that, you can put various metal blocks. Either you can choose a 6 mm rod like a shank spin, or you can make 8 mm rods or some, just to go between the plate and then the bone. Because you have exposed that area, you can just keep it one block like that and then complete your fixation and then come out and then take it out. At the end of it, this will appear like this. There will be a gap between the plate and the bone. You understood now?
Yes, sir. Super, sir.
Sir, and where do you draw the line between grafting and not to graft? When to graft in case of, even if you do a biological fixation, we don't graft, of course. But when do you decide to graft it primarily, sir? When you use locking plate?
We graft only in open injuries. Primary bone grafting we do only in open injuries, not in closed fractures.
When you are not convinced about the medial void, sir, because if there is a huge void on the medial side, do you want to graft it, or you think of only nailing, sir?
I have not done it for fresh fractures. Except open injury. For open injury, we do primary bone grafting.
Okay, sir.
So, sir, one more question, sir. So, when will you advocate dual plating for distal femur, sir? You are absolutely
in a non-union scenario, you can go in for a dual plating. So, especially if you see, for example, this is the way I plan. Suppose if I don't have to remove a lateral plate, if I have to address only the medial void, it is simpler. You just go through the medial approach, put a bone graft, and then add an augmentation plate on the medial side. So this is a dual plate. Whereas sometimes there is a lateral plate broken. You have to definitely remove it. So you remove it. In that scenario, what I do is we use medial side. We peg the allograft on the medial side. You can use fibula and then peg it on the medial side and put a lateral plate. But even then, if you think there is a medial void, then only you can go ahead to do on one more approach and then put a plate. Am I clear? Am I clear to you?
Yes, sir. Yes, sir. Very clear, sir.
Very clear, sir. Very clear, sir. Nearly 100 participants, sir. Very nicely that they were still awake and listening to your talk, sir.
Thank you.
Very nice of you, sir.
excellent lecture, sir.
Excellent, sir.
The more because it is going to be of great use, sir. Because we are there in almost all the sessions, sir. I think our knowledge in orthopedics has definitely improved a lot. In
100%,
practical and yes, sir.
If you listen to anyone, some points will be there. They will always give you some points.
Yes, sir. So every time we are learning, sir, and again there are so many more points when we listen to lectures like you, people like you, and we start learning more and more, sir. So thank you for a wonderful and thanks for your time, sir. When we were at the PGs, we did not have such opportunity, sir, to meet legends. பேர் தான் சார் கேள்விப்படுவோம் கான்ஃபரன்ஸ்ல இவர்தான் டிடி சார் இவர்தான் எஸ்ஆர் சார் அப்படிலாம் சொல்லுவாங்க. But now we have the PGs have the opportunity to listen to people like you. I think it is
we are there anything for TNOA, because SR also will keep on telling TNOA means yes, go ahead.
No, sir, that opportunity is there, no, sir, for us to listen to people like you. And only we have just heard by names when we were PGs, the legends were there. Now they have the opportunity to mingle and hear and also to clarify their doubts. I think that is a wonderful opportunity for. I think thanks to COVID, sir. I think it indirectly it has helped us to get this session moving.
நீங்க தானப்பன் சார் நீங்க தானப்பன் சார் அப்புறம் எல்லாம் நீங்க இந்த பிஜிடிஜி ப்ரோக்ராம் மாடரேட்டர்ஸ் எல்லாருமே
we can go offline and then discuss, or
yes, sir. No, sir, we have almost closed, sir. We almost closed, sir. And we'll just for just a couple of more minutes if you have any questions.
Actually we finished much early, sir. Usually it will go up to 11 o'clock, sir. So we covered everything in a short period of time, sir.
No, I am not a guy who speaks for a very long time.
You covered everything, sir. It's excellent.
Message only is important, sir. I think the message is important. I think when next time or locking plate PG edutha udane, I think now he has to think. I think you given them the thought process. I think the thought process is more important, sir. And after listening to the lecture, definitely the thought process will kindle them to know about that plate and to understand it better, and to come back to listen to a lecture and go and read it also. I think that thought process has definitely you have given the thought process today, sir. And all the messages there, maybe if they don't understand all the messages, I think every time they get that doubt, I think the doubts should be cleared, sir. In English, I think a lot of doubts were there. So now it has become little clear. And next time, when we have such a doubt, I think we have to, apply whatever you have taught today, sir. Definitely would be very useful. And not only PG, sir.
Whatever is required in a plating, I told. So
Yes,
I think
everything has been covered, sir. And it is not only about the PG, sir. A lot of consultants are there in the group. So even a lot of consultants I know, even in Chennai, a lot of people and even assistants and a lot of consultants are there in the class today. I think
very good. Thank you.
Great learning experience for them also, sir. And YouTube also, within a week or 2 weeks, 500 to 1,000 views are there, sir. So it is the message is getting spread, and whenever a person like you of your caliber comes in, the number of views are high, and also the number of live viewers also are very high, sir. I think today
rating increase ஆகுது சார் மாதிரி ஆளுங்க வந்தாங்கன்னா இல்லப்பா.
Yes, sir. Yes, sir.
Yes, sir. அதனாலதான் சார் திடீர்னு இல்ல
ரஜினிகாந்த் வர மாதிரியும் கமலஹாசன் வர மாதிரி சொன்னீங்களா?
Meenakshi, எங்க everything is normalizing. No, we can all meet, I think.
Yes, sir. Yes, sir. Yes, sir. Sure, sir. Sure, sir. So thank you, sir. Thank you for your wonderful lecture and your knowledge, sir. Thank you, sir.
Thank you all.
Thank you, Meenakshi. So we thank
thanks sir.
Video editor Meenakshi also for having been very எப்பவும் போல அவங்க lively ஆக்கிட்டீங்க சார் இந்த program. And thank Thana.
நம்ம இருந்தாவே எப்பவுமே கலகலப்பா இருக்கணும் சார். அவ்வளவுதான்.
ஆமா சார், அதான். Yes, sir. So thank you once again.
Thiru and Suresh. Yeah.
Suresh. Yes, sir. So
Thank you, sir.
Thank you, sir.
Thank you, sir.
And Alambic, thanks. Alambic also
PTS sir இருக்காரா? Secretary sir.
PTS இருப்பார் சார், யூசுவலா இருப்பார். அவர்
இருக்கேன் சார்.
சார் வாங்க சார். Thank you sir.
PTS இருக்காரு, எனக்கு தெரியும் அவர் இருப்பாரு.
Thank you PTS.
Yeah, thank you sir. Thanks very much sir.
Tanapan sir, thank you.
Thank you so much, sir. Thank you, sir.
Meenakshi, thank you.
Thank you sir.
Thank you, sir. Thank you, sir. Good night, sir. Good night, sir. Good night.
Thank you.
Thank you, sir. Thank you, Alambic also.
Thank you.
Thanks to Alambic.
Thank you.
Thank you.
Programs.
Yes.